are not finding any clue to the genetic etiology, then we will consider it as unexplained. If we are able to find out something, then definitely we can do a battery of genetic investigations.
So we should offer her only karyotype or something else?
Karyotype, yes, that can be offered.
So patient got evaluated.
One thing I'd like to add is
Yes, sir. Yes, sir.
to see the father also, and you can examine the father also.
Very true.
To get a clue if the baby has some sort of inherited anomalies or any karyotype.
Karyotype of both parents.
Because many times we see the kids and we do see the father and the mother, not complete, but observation is good enough to have a grossly abnormal karyotype.
This is the most important part of Sherlock Holmes technique, is the observation.
Yeah,
so we all
observation
need
is
to
the most
be a good observer.
And of course, pedigree chart helps you a lot. So making a pedigree chart for all those patients where you don't know before you label it as unexplained, we must put all our effort to find out in history and in their family history to find whether they have a history of losses in the close family group. Pedigree chart helps you to...
That is a very important message, ma'am. Very
And
important.
one more thing I want to make a point here, reinforcing Dr. Naveen's point. He said we should have a look at the father. I say so many times we miss to have a thorough look at the mother. Recently, we had an early neonatal loss of a very premature baby I delivered. And we looked at the baby was hypotonic right from the birth. So after all the genetic tests, the diagnosis came out to be congenital myotonic dystrophy. And when the pediatricians examined the mother, first baby, absolutely normal. Now, second time when I looked at her, I said, yes, she has this, different faces. So many times in our busy OPDs, so especially a mother who comes with a stillbirth, we can open our eyes and be Sherlock Holmes once again.
Yes.
Yeah, the
Good
severity,
message, ma'am.
The severity and the spectrum of disease can vary. You will have a nearly normal or mild disease and which can survive to the adulthood, and like the mother and the father. And you have a fetus is very severely abnormal. And
That is where the role of pedigree chart comes. So patient got evaluated. Her BMI was 28 and there was no risk factor which was found in the history, and investigation turned out to be normal.
And we also got her karyotype done after this discussion. So it was normal.
So my next question is to Dr. Seema. What is the ideal time to plan pregnancy now?
So in this mother who is 28 years old, she's illiterate. So when she comes for, we are very lucky that she came for a pre-pregnancy counseling, because half of these people will come back to you pregnant. So she seems to be a Cloud9 patient who has come for pre-pregnancy counseling. So I think we have to guide her that the minimum time period, which should be as a result of planning at least 6 months. They should defer the next pregnancy, should not plan it before 6 months interval. And if unfortunately she's had a cesarean delivery, any other patient, then the interval should be at least 18 months between the two babies.
This is very important because in our setup, usually the advice given by the most of our family members is jaldi se bacha karo, abhi purana bacha bhul paoge.
Although if she conceives accidentally, you counseled her for not conceiving for 6 months, it really does not matter too much if it is beyond 3 months, because the incidence of stillbirth is not found to be more when you talk about 3 months or 6 months.
Yeah,
so
it's not a confounding
it's
factor
not
in the perinatal outcomes.
Yeah, but then definitely literature goes and says that it is better that you ask them to take 6 months.
I think, ma'am, emotionally and physically also the lady has to be strong, and it takes some time. 3 months I feel is too less a time, so that is why I think 6 months minimum should be there.
So now let's go to another case.
Sorry.
Yeah, so they say for a scarred uterus, 9 months is the interconception interval, and then 9 months pregnancy. So 18 months interdelivery. 18 months total interdelivery. Yeah,
yes.
To delivery. 9 months. 9 months.
Yes.
Exactly.
So now let's solve a second case of the day. It's a 31 years booked and supervised, reported in obstetric emergency at 38 weeks of gestation with complaint of absent fetal movements. She was seen by a resident who reviewed her record and found no high risk factor. She was last seen at 37 weeks in OPD, and today at 38 weeks there was no fetal heart on auscultation. Ultrasound also confirmed that it was a IUD. So now I would like to ask Dr. Radhika how to break the news and what is the right way of doing it.
Yeah,
Hello. So first of all, if she's alone, if she is presented alone to us, I would like to offer to call some of her family member or partner or any person that she can rely on to be of support to her, because it will be a very devastating news for her. So I would like to offer to call someone. And second of all, I would like to be empathetic towards her in breaking this news, and to first of all I will set a setting as to assess how much knowledge and information she has about this, and then I can then communicate to her as to what circumstances have occurred, and then
So you will follow some protocols,
yeah,
some
so there's a
models like spikes model, breaks
yeah,
model.
which first sets the
So
setting.
this is very important. Like you can't just break the news as such. You just can't talk to her. So there are some methods and there are models which are given that at certain the how should be the environment, how to break, how to convince relatives should be there. So that is the right method rather than just putting the news as such.
It is
So
very, Dr. Aarti, it is very easy to say that we will follow all these models, but what actually tells, reveals the story is your body language. The moment you start looking at the fetal heart and you don't find it, the patient comes to
ma'am,
know
for
about
medical
the.
legal reasons also we've had to follow. Sometimes husband can say that after she declared the news, my wife is not well.
Absolutely.
So when we follow some protocol, we are medically, legally safe also.
That is
It's-
precisely what I was
yeah.
coming at. So, what reveals is your body language. So, when you are examining the patient, when you can't find a fetal heart, I think it is how you converse and dictate until you get an
Very true.
ultrasound that makes the entire basis of how you're going to break the news.
It's very difficult situation to handle, and
Dr.
we
Tanka,
all
so the
need
first
to.
For the
step is
doctor
prepare
also.
yourself. So
For
the
the
first
doctor
step is
also.
prepare yourself, because we all get equally shocked the moment we see an IUFD.
And she was booked. She was booked. Yeah.
Yes, of course.
Dr. Seema, how to plan her delivery? Do we have options for expectant management?
See, in this case, once we have broken the bad news, I think the plan for her delivery will be after taking the family and the patient into confidence. So, as a doctor, I think it is our discretion first to assess her medical health, do a coagulogram, do a platelet count, assess whether she's had prolonged rupture of membrane, any sign of infection, any abruptio which we have picked up on ultrasound, or there's any risk factor to the mother, like
So we
high
should not
BP,
hurry up the
preeclampsia.
things. We should
Yes.
take our time.
Yeah.
That is most
Yes.
important. We
So
should
what-
not create panic.
Yeah.
Because
So-
doctor will also get panic. Yeah, you booked patient IUD now. What
Yeah.
to do?
Yeah.
Just we should not panic. That alarm should be not be there.
So
We should
once
take
you
our
have-
time, investigate her, and then
Once you have assessed the medical condition of the patient, then you should talk to the patient and the family and understand their state of mind. For example, I had a scenario where the patient was an IVF pregnancy. In 8th month, at the age of 46, an IVF supervised pregnancy, had a sudden IUFD, and the family was not ready to take the patient home. They said she was a villager. The moment she goes, there'll be a whole lot of chaos. So, Dr. Seema, you have to deliver. So there are certain circumstances. So the ideal thing is we should give an expectant management, let the patient go into natural labor. Twice weekly do coagulogram and platelet count to ensure there is no DIC coming up. But yes, there are few scenarios where the patient's circumstances or the emotional health warrants an early delivery.
So always theory will not help.
Yeah.
We need to see the
has to be
scenario of
tailored
the
according to
patient, family,
And,
and
the
then
mindset of the people who are
And-
she's
but-
with them.
But
That
we
is
should not miss investigations.
Absolutely. I remember a patient, I was a resident in PGI, and we had a patient with some muscular dystrophy. Exactly, I've forgotten, but previous to cesarean, and presented to us with a stillbirth. And we gave her about 3.5 weeks, and she went into spontaneous labor and delivered subsequently without any complication. But the ordeal, staying somewhere in Jammu Kashmir and making her stay close by in the Sarai, getting her investigated twice a week. I mean, in private sector
The
also, it's a
model of
difficult thing.
doctor also.
Yeah.
Yes, of course.
Waiting
so
for
it's
so
a great
long.
difficulty, but she did not end up in sepsis as the family would put up,
True.
and we managed to deliver her.
It takes a lot of courage to wait
Absolutely.
up to 3 weeks.
No, like in PGI, we have a very high load of stillbirths. We have around 350 stillbirths in a year. So we do give expectant management and we wait for 4 weeks. We don't induce any stillbirth if it is not an emergency.
What are the advantages of immediate delivery, Dr. Itam?
Yes, once you've ruled out that you don't need the expectant management, the advantage that you lose out is that you don't have a evaluation of the fetus morphology, and you lose out on genetic testing of the baby, because by the time the 3 weeks go by, the baby becomes macerated. You do not have a dysmorphism which is
Exactly.
picked up, and you
This
don't have
was my
any tissue,
point.
any tissue which you can send for genetic evaluation. But in case you know the genetic basis is fine, I think we still should vouch for a expectant management.
Absolutely right, ma'am. This lady was induced and delivered a stillbirth after 12 hours of admission. It was a boy baby of 2.1 kg. So now I would like to ask Dr. Radhika, the next morning you are on rounds, and how will you review this case? Key points in history you would like to know that.
So first of all, we'll take a proper history. We'll cover the obstetric history, the medical history, the family history. In obstetric history, we'll see, first of all, starting with the age. If her age is less than 15 or more than 35, so they'll have high chances of stillbirth, parity, and her medical history of diabetes or chronic hypertension or Apla syndrome, or any
Sorry
renal
to
disease.
interrupt you, but we would like to know what all things you want to ask, whether there was any abruption or what was the placental finding,
so-
intra-delivery notes, what all things you are looking for.
Notes
Yes.
also, we would like to know if there was any cord accident, if there was any retroplacental hemorrhage, or if there was any cord
Meconium
prolapse
was there.
or meconium. All these things we would like to know next day on the rounds in our history to establish the cause of stillbirth.
Very rightly said. Now, Dr. Garima,
I think one history
what
we
all
are
things?
one history we are missing here is the trauma or the abuse to the female. That is also important in our society.
Trauma or abuse of the mother.
Yeah, of the mother. Yeah.
I remember a patient of mine, I had done her, she was a primary, supervised, well supervised. We did a scan, and coming from an average middle socioeconomic class, at 36 weeks, she came to me, we did a scan and everything was fine. I sent her home. And incidentally, she came back in 2 days with an IUFD. On questioning, I found out that she had been having itching, for which she was applying coconut oil. She said, "Ma'am, मैंने अपनी mother-in-law से पूछा था, उन्होंने कहा सबके होती है." So I did not bother to say.
So I think small
usually
points
not.
can lead to the cause.
So-
Very good, Dr. Naveen, the trauma, abuse, and then asking the history, which they might think that this is not important, but we need to extract it.
I feel the incidence of cholestasis in this northern India is so high compared to southern India. I make it a routine to ask every single antenatal patient after 30 weeks, do you have itching? It has become a routine practice to most of us now.
Yes, it's a very
Very
good
true.
practice because we have to.
Because it's very high.
So maybe they will not come with the complaint.
And if
It's
you
better
get-
we should ask.
And even if otherwise she doesn't have itching also, or very less itching, you get an SGOT, SGPT,
It's
it will
better
be
to get
raised
LFT
in
rather than
60 to
having a
70% of the
stillborn.
patients, I feel.
Dr. Naveen, what should we look for in a stillborn baby?
Yeah, your question itself has stressed upon the point that not only delivery of a live fetus, even if we have a delivery of a stillbirth, then it should at least be examined by a neonatologist, that stillborn baby. So what we need is the basic parameters. It's still the weight, head and length, head circumference and length. It will tell us about if the baby LGA. LGAs are bad. Diabetes is the most common cause. SGA, the severer the SGA, the worse is going to be the outcome. Will suggest that the chronic hypoxia was undergoing this fetus in utero. Now, suppose you don't have the person expert available at that time, at least do these parameters a staff can do and have the photograph of the baby, and from photograph itself or by examination any dysmorphic faces, any typical chromosomal anomaly, normally karyotype abnormalities like a Down syndrome, Patau,
Faces.
trisomy 18 and 13 can easily be picked
So
up
this
by
is an important
examination
message.
at birth itself, and it is an important clue for the next pregnancy. And then you will do the karyotype accordingly. We had that you can do karyotype of the parents and see the risk in the
So
in
most
next
of the time,
pregnancy.
sir, what happens that obstetrician, they whenever it is IUD, they want to hurry up, deliver and discharge. So what the message is that at that time there is a very important role of neonatologist. Very important role. What happens that they deliver in and they just want that this case should go and other patients should not come around. But there is a very important role of neonatologist. Even if you feel that you can't call, taking photographs and then showing to an expert will also help. But the best thing is include a genetist and include a pediatrician.
And only thing you can't do here in stillbirth is the auscultation of the heart and the breast sound. Everything else, all other examination can be
Very
done
true.
in just 5 to 10 minutes.
So this
time.
is the message
And
that
do not forget, I'll highlight that the placental examination again is very important. And then normally whenever we teach a examination at birth, when you attend a delivery, the placenta should be examined. But here it becomes more important to have a examination of the placenta. You will find uh, abruption, calcification, torch infections, and insertion of the cord, and so many important things apart from the how weighty the placenta was it
Very
the
important.
ratio with the weight was appropriate. And here you had a
even in the
SGA
cord, whether there was a true knot,
and
there
meconium
were
staining
two
of the
knots.
cord.
True, not here.
Yeah, meconium
So-
staining of the cord. Here you had a baby which is definitely an SGA baby was chronically hypoxiated.
Yes.
Sir,
So our patient, she had a headache and her admission BP was 150/100. So her antenatal investigations, the aneuploidy screen was low risk, level 2, there was no CMF, and at 32 weeks of scan, her growth was appropriate for gestation age. In delivery notes, they have written that Liker was meconium stained, no retroplacental clot, and it was a boy baby with birth weight of 2.1 kg at 38 weeks, sorry. So now I would like to ask Dr. Ritamra, how will you classify it as per WHO ICD-PM system of classification?
WHO ICD-PM classification is a fantastic classification system which has been devised, and I would like the people sitting in the audience to go through the literature. It is freely available, and download and use it on, and no child should be missed this opportunity of getting a classification at that before the discharge. So how do we go about it? First, we have to, we know that perinatal period includes antenatal, intranatal and neonatal period. So we have to classify stillbirths in the two groups, antenatal and intranatal. That's the first time. Second thing is to find out what is the main cause of stillbirth. So that has to be found out. And then this third step is to link it with the maternal disease. So antenatally, when you are able to get the disease profile, and we are able to classify. So it is important for us to know to follow this classification. Antenatal classification has been beautifully divided into 6 groups, 1, 2, 3, 4, 5, 6, where we have congenital malformation followed by infections and other antenatal disorders, then fetal growth restrictions and disorders of growth and unclassified group. In the intranatal, we have congenital malformation, birth trauma, antepartum event, infections, and other specified intrapartum disorders, followed by fetal growth restriction and an unclassified group. So basically, we have the entire etiology of antenatal events as well as intranatal events which are classified, and you have to give a particular category to a stillbirth. Then you come to correlate it with the maternal conditions. We have a list of 1, 2, 3, 4, 5 conditions where you have to fit to an underlying maternal disorder. Once you have fixed a maternal disease and an antenatal or an intranatal diagnosis to the stillbirth, you can tabulate into a particular chart where you can have the antenatal events on one axis and the maternal events on the y-axis, and you can decide as to where that baby would fall. So type of stillbirth, then you would have the cause. Here in this case, we have a fetal growth restricted baby, and the underlying cause is hypertensive disease. So the classification for this particular baby would be A5M4.
So
That is
like we have
IUGR.
checklist before going to OT, we can use such checklist before labeling the patient.
Mandatory should be used.
Yes,
And
mandatory.
I just want to, ma'am, you have explained it very well, but I would like to add that it is an extension of ICD-10 coding. We are coding each death in ICD-10. So it is an extension for perinatal mortality. So we should classify each death, including stillbirths.
So my next question is to Dr. Naveen only. What all investigation you would like to offer for fetus, and what is the role of autopsy?
No, autopsies probably can reveal the most of the things which are there in the baby, but I understand it is not so easy for in our society to have the autopsy.
So what
done
is
on
your
the
point
fetus.
of view? You will recommend autopsy
Yeah,
to
I-
all,
we-
then you can write that they refuse for
Yes,
autopsy.
we should be recommending
this
it to
is-
all, whether it might help in medical legal purposes
Exactly.
also. So it should be recommended for all the stillbirths. But if that is not possible, then at least we say a partial autopsy. Along with the clinical examination, you get a X-ray. The babygram easily can be done and is very cheap. Ultrasound can be done easily. And sometimes the MRI also can give a valuable information. And I like to stress the infection is very important, especially in our setups. You know, in the Western world also you have incidence of around 20% of the deaths because of the infection, and mostly it is viral in those cases, or the GBS, group B streptococcus, if we talk about the bacteria. But in our country, the bacterial infection incidence is much higher than the Western world. So for infection to get detected, because in the next pregnancy also you can have a recurrent infection, you will have a history of UTI, and you can get have the clue of infection from the placental histopathology also.
So important
And you can
point
take
that
a
we should
small-
consider infections
You can take
also.
a small skin tissue or a cord tissue, or possible then the blood as a specimen can be sent for the genetic testing also. Those tissues can be sent.
In COVID era, we had a policy of getting placental histopathology for most of the placentas
True, ma'am.
that would, where we had a history, and we had a specific inflammatory response in the placenta. So I'm sure a placental evaluation goes hand in glove with the autopsy. Unfortunately, in private sector, we don't have a facility for fetal autopsy, but collecting biopsies from various places and
partial
sending
autopsy.
a partial autopsy, as well as getting placental evaluation, thorough placental evaluation, at least can that can be part of our work.
You're absolutely right, ma'am. So now I would like to ask Dr. Sangeeta, what about placental pathology? How it is going to help in subsequent pregnancy?
So most of the things have been told about my colleagues, but I would like to add placental pathology will carry a meaning if done by trained perinatal or pathologist, because they know what are the findings we have to click upon, and what are the findings which can lead to recurrence, or they can like infarction, or if there is cord abnormality or membrane or any infection is there, then we can definitely tell the couple that there was an infection, and this is a sporadic chance, and this would not like to be repeated. But if placenta, and one interesting thing is that sometimes placenta can add, placental examination can add to genetic etiology in some cases, because some fetuses with fatty acid oxidation disorders, they have particular findings in placenta. There is perivillous fibrin deposition, which can point towards fatty acid oxidation disorder. They can lead to IUGR as well as stillbirths. So good trained pathologist is very important in this case.
Very true, ma'am.
So ma'am, I would like to ask you how to take the sample for cytogenetics.
So in
And
this
how to
case,
store.
this is stillbirth. You have decided the classification, etiology has been decided. But in my sense, if I see this case, single reading of high BP on admission, 32 weeks scan was perfectly normal with no IUGR. a single reading, I don't think might justify the cause to be non-genetic or hypertension only. We should always keep the possibility of having genetic disorder.
Even in late
Even
FGRs,
if a single reading of high BP was there, and because IUGR is
even in late onset FGRs,
yeah,
it was late.
even with IUGR we have so many single gene disorders without any morphological abnormality in the list, like inherited cardiomyopathies and channelopathies like long QT syndrome, that will not have any morphological abnormality, and that increased BP can be coincidental. I'm not saying that this could not be the cause, but
So, sorry to interrupt, exactly similar case we had. I had a mother whom I admitted for severe preeclampsia. Mother had IUGR, and as obstetricians, it was very straight for us. We delivered the baby, baby had arrhythmia, and baby had abnormal QT interval. So once in a while, IUGR.
So
the
that
cause
is why
will be-
the thing is that we should involve a geneticist.
yes, it's
Whether we know the
always
cause, whether we don't know the cause.
unless proved otherwise, there should be always a genetic possibility.
Therefore, I think as a gold standard, we should do some genetic evaluation when you have a stillbirth, even though the cause may be there. You may be taken by surprise next time in the next pregnancy. So then
Yeah,
it will
that's
come back.
true. So we are not able to answer that time when there is a recurrence.
So, ma'am, time is running. There is a small case that she is a 27-year-old, gravida 2, P1 plus 0, previous unexplained stillbirth. Now she has come to you with 2 months of amenorrhea. She is pregnant. Do we have preventive strategies to avoid such mishap, Dr. Seema?
Can we just go back to the history once again?
she had an unexplained stillbirth. She was fully evaluated and we did not find any cause. So now she is again pregnant.
I think after learning a lot from Dr. Ridamra's classification, 90% of patients we should reach at some diagnosis. So I would revisit the history, try to explore as much as I can, and if it is one of those 10% of the cases which are actually unexplained, then I think we have very little to offer. But surely it is going to be an ultra precious pregnancy for us. So we will be very careful in monitoring our baby for the growth velocity, and if need arises for the Dopplers, and we would look for all maternal comorbidities in the current pregnancy.
And during delivery also, we'll
Yeah.
be very careful.
So now I would like to ask you, ma'am, like now she has come pregnant, right? So now how we'll investigate this patient? She has come in her first visit at around 9 weeks.
Being a PGI trained, I would go back and re-evaluate the history. And if I still label it as an unexplained, probably then I would reiterate what Dr. Seema did to monitor her thoroughly throughout the pregnancy, tell her to be more vigilant, looking after her movements. And the guideline says that you must start strict monitoring 3 weeks, 2 to 3 weeks prior to her last stillbirth. And if it is beyond 32 weeks, be very, very careful, because most often it is the placental etiology which has been missed, and the placental etiology needs a strict monitoring and ultrasound for fetal Doppler throughout the pregnancy, and of course a supervised antenatal care and delivery.
And dating ultrasound is very important.
Absolutely. Dating ultrasound goes.
So the next question is from Dr. Garima. What all screening to be done in this case, and is there any role of Doppler and Papa, uterine artery Doppler?
Along with the routine investigations that we have already discussed, I will not repeat those again. Let's straight away go to the PAPE. PAPE as a marker has come up a long way. It just guides up the low PAPE, the mom values. They are directly linked to the small for gestation age babies, predicting the incidence of preeclampsia we are going to get, and predicting the incidence of stillbirth as well. They all go hand in hand. Basically, they are all linked with the placental insufficiency that patient is going to develop. And if the PAPE mom is like less than 0.8, so we should actually be starting her on further aspirins. There are a lot of studies done on that also, that we have to start aspirin. Another role of uterine artery Doppler comes up also. There's a PI needs to be seen. Though we were mostly doing uterine artery Dopplers previously at around 18 to 24 weeks, but now when the NT scan is being done at 11 to 13 weeks at the same visit, uterine artery Doppler is advisable and is done. Though it's more difficult to be done at this time, But still,
people are
if
doing it.
yeah, they're
And
doing
is
it, and they're
quite
doing it
good.
very well, and they're predicting the incidence value very nicely.
Very nice.
So because the placental tissue that starts at 10 to 16 weeks. So if we intervene at right at that time, so it can really help for the patient.
So this is the next question from Dr. Radhika. Is there any role of low dose aspirin? If yes, when to start?
Yeah, so if the uterine artery Doppler pulsatility index comes more than 95 percentile, we can start the patient on low dose aspirin. It should
No,
be
but in
started-
case of previous unexplained stillbirth, when are you going to give her or not?
Yeah, if, we will investigate her, and if we see some